Sex education now in the United States of America is worse than it was in the 90s. And we don't get good biologic sex education. Women don't learn about vulvas or clitorises at all. So we don't get taught about the organ of pleasure. We think the vagina is where orgasms come from, which they can in some people. But really the clitoris is the penis. That's the homologous structure. So we don't get taught biology. We don't get taught how we're socialized to think about sex, how we're socialized as women. We're penalized, right, for touching ourselves, for enjoying pleasure. So we're like taught, but we don't get taught the ocean that we're swimming in. And then when it's not pleasurable or it is challenging or you need to talk about it, you feel equally broken about it because of the way you were socialized. So sex ed needs to do better. And that's why I'm like, adult sex ed needs to happen, because when you get taught sex ed, as crappy as it was, you were not in like a long-term committed relationship or on your sixth relationship or after a cancer diagnosis or after a divorce. Like life hadn't happened yet before you got sex ed. So it's like you get shitty sex ed, then life happens, and now you feel broken about your sex life, right? Like I would say that's probably the overarching thing here. And so I swoop in to be like, okay, adults, let's back up. Let's learn some basics. Let's break down our limiting beliefs. Let's decide that we're not broken and decide that we can do something about it. The book and the podcast are named You Are Not Broken because women just kept telling me that they were broken. And I just kept hearing that over and over again. Women are like, I've never had an orgasm. Like, you're not broken. About 10% of women in our culture have never had an orgasm. Most women can have an orgasm biologically. It's very rare. There's an issue with the clitoris. But sociology, again, not being allowed to touch yourself, pleasure is bad, masturbation is bad. So you don't know how your body works. You don't know what causes pleasure. And then you do the linear sexual script of a heterosexual relationship. You put something in the vagina, you don't have an orgasm, and you think you're broken. And it's like, no, you're not broken. You didn't get any education. Let's help you out. 48-year-old, sleep disturbances, some belly weight gain. Sleep most bothers me is HRT patch versus oral progesterone only or IUD. Great question. So let's back up and do some education about perimenopause, because even in medical school, oh my God, for all the people here who maybe went to medical school, I didn't get taught that ovaries make more testosterone than estrogen. Learned that a couple of years ago. Never taught that perimenopause was a thing. Never got taught about the roles of progesterone. Right, so like in order to answer that question, because I know you can handle it, let's back up a little bit, talk about perimenopause. So perimenopause just means the years surrounding menopause. Depending upon your definition, it can be 10 years before your last menstrual period. Some people will include it to be like a year after you haven't had periods. Back up for the people in the back, menopause is 1 year, no natural periods. Average age in America is 51. Not a useful definition for two reasons. Number one, when your periods end, doesn't freaking mean anything except for fertility. But I would argue many people can't have a baby even while they're having periods at the end. So people think that they had no periods is what menopause is. Ovarian cessation of hormones is what midlife is. People don't like to call that menopause because menopause technically means no more bleeding. But ovarian hypofunction, female hypogonadism, midlife associated hypogonadism, right? Like we don't have a term for actually ovarian cessation of its job. So menopause just kind of means end of bleeding, right? Which we know, experts know, the hormone fluctuations start years before that last period. Also not helpful for people who had hysterectomies or have IUDs or have had ablations where they don't have a bleed to tell them when menopause is. So your question is, I'm going to guess you said perimenopause. Perimenopause, sleep disturbances, everything works well for sleep. Testosterone works well for sleep. Estrogen works well for sleep. Progesterone works well for sleep. And then hormones get stereotyped, right? So progesterone is kind of and what I mean is body identical, what your body makes, progesterone, which in prescription form is oral micronized progesterone. That's as close to the progesterone your body makes that we can get. Notoriously, its reputation is sleep. It has GABAergic action in the brain, which is relaxing, it's calming. Some people will call progesterone God's benzodiazepine. It's very, very chilling. It's also short acting. We don't have a long acting micronized progesterone in this country. So you take it right before bed and it can help sleep. So you can basically, to answer your question, you can try any of it. Stereotypically, testosterone goes down first, then progesterone. Estrogen can actually go up because it's trying to ovulate, right? So you can get kind of really high estrogen in perimenopause. So a lot of people who aren't hormone experts, they'll be like, just have an estrogen patch. A lot of people who aren't hormone experts will say you can't have anything until you're done bleeding, and that's absolute bullshit. That's not true at all. So to me, I'm like, you could do whatever you wanted. But the belly weight gain, you're probably going to get more bang for your buck starting on an estrogen patch for that one. Probably progesterone to start with sleep. But I would say it's all worth a try. IUDs are great for protecting the uterus from unopposed estrogen if you're going to do a patch, but IUDs aren't going to give you the progesterone for the brain that helps with sleep. So for that reason, I'm like, I love IUDs. I love, love, love IUDs. The other thing about perimenopause, you can still get pregnant. And being on hormone replacement therapy, which is not birth control is synthetic and works by being an antagonist or similar but blocks the receptors, right? So that's why you don't get pregnant on it. Menopause and perimenopause hormone therapy or bioidentical hormone therapy or hormone replacement therapy, these are all interchangeable words. You can get pregnant on that. So caution. So I always ask people, I'm like, do you have sperm in your life? Because if you have sperm in your life, IUD, you can still have an IUD and take oral progesterone. But a lot of people also will give perimenopausal women birth control pills. I don't believe in that. They're really high dose. They've got higher side effects and they've got testosterone blockade to a lot of them. So to me, I'm like, if you need to be preventing pregnancy, yes. But if you don't need to be preventing pregnancy, then I wouldn't go for oral birth control pill. But especially about 20% of women in perimenopause will have increased bleeding risk. Heavier bleeding is what I mean. So if you are that, and that is usually because you're having really high estrogen spikes and really low progesterone. So it's like all thrown off and you have a big bleed after not having a bleed for a while. So that's what IUDs can be great for that. So I hope that answered your question. Somebody just said that they're a boomer and they're pissed. I love it. One of my most listened to podcast episodes is called The Boomer Should Be Pissed. It's old now. It's probably at least a year old. And the reason I did that episode is because first of all, the Women's Health Initiative, which scared everybody off of hormones, is 22 years old. And the boomers, by and large, were like 50 when that dropped. So like they got, like this entire generation thinks that estrogen causes cancer, basically. And now they're learning like, oh, oops, sorry. And which if people want me to go into, because we've got the luxury of time on this webinar, if you guys want me to go into the WHI and why it isn't what we said it was, I'm happy to. It takes some time, but it's a great topic. And then you can educate all your people. So now the boomers are 68. I had a woman very recently, 68, hasn't been on hormones. And a lot of these people are told that it's dangerous, it's not safe, that the risk is really high, it's not going to help. They're just kind of told all these things, that they absolutely can't be on hormones. So that's not true. The 2022 North American Menopause Guidelines, which you can look up, says the best time for the greatest benefit and the lowest risk is within 10 years of menopause or age less than 60. It does not say you can't after 60 or 10 years past. Doesn't say that. What we know, people who start on hormones later are still getting bone benefits, which is huge. You're still probably getting some cardiovascular benefits. You're probably not getting the dementia prevention, because from the meta-analysis that we have right now, you got to start the hormones early, because we can't be years and years and years without estrogen and then start hormones and think it's going to protect the brain as much as starting the hormones when we're 50 or menopause. So you can start it later. You're probably not getting the same benefits as if you started when you're 50, but we can't turn the clock. I can't put you in a time machine. I can't undo the WHI, but I can say, what are your risk factors now? Can you be on low dose transdermal estrogen for all the internists in here? Doesn't go through the liver. The liver is where clotting factors are made. Ergo, oral estradiol goes through liver, clotting factors, increased risk of blood clots, and therefore stroke. But very low. Lower, even with oral estrogen, your risk of blood clot and stroke is lower than that of younger women on birth control. Birth control has a higher clotting risk than oral estrogen. And I would argue most people, most prescribers, will put people on transdermal estrogen now to basically say you're not increasing your clotting risk or your stroke risk when you're on transdermal. So that is my long-winded, I put tons of boomers on hormones. Side note, genital urinary syndrome of menopause, or GSM for short, there's actually a group of people who are looking at rebranding that. I think just for genital urinary syndrome of low estrogen or something like that. There's some people are trying to get the menopause out of there because perimenopause women have, because remember, hormones go low before your last period. But anyways, GSM, treated with vaginal estrogen, most commonly. Everybody can be on vaginal estrogen. Everybody. I did this reel like a couple of days ago. People were like, how old is too old for vaginal estrogen? And my answer to the reel was like, the day before you die. You're not going to get much benefit out of it because it takes like 6 to 8 weeks to kick in. Very safe. And if people go get any takeaways for any hormone knowledge, is knowing the difference between systemic hormones, which is all body, bones, heart, cardiovascular health, skin, gut, all the things, muscles, insulin resistance, sensitivity, versus vaginal or local. I call it pelvic on Instagram because I don't know when Instagram's going to kick me off for saying vagina. I call it low dose pelvic estrogen, but that's just in your pelvis. Doesn't protect your bones, doesn't protect your brain, doesn't protect your heart. It's only for bladder and vagina, vulva, clitoris. So 2 different types of hormones. You can be on both. Because remember, replacing your hormones with systemic hormone therapy is still really low dose hormones. It's still not what you were doing when you were 28.